So I've deliberately put this slide as a starter because what it shows is that this guy, he's Phidippides, and in 460 BC, he ran 26 miles basically from a place called Marathon to Athens in Greece to inform them of some big important Greek victory that the Greek had over the Persians. So the poor guy ran naked for 26 miles, informed the Greek people who were obviously quite happy, and then he dropped dead. So this is the first recorded case of an athlete who's dropped dead. And obviously in the last 2 years, I'm sure all of you who are avid fans of sports have realized that a lot of people have been dropping dead or nearly dropping dead in the last couple of years. We've had the marathon runner who recently dropped dead, and then one of the Norwegian swimmers as well. And all the footy fans amongst you are aware of the fact that Fabrice Muamba nearly dropped dead on the football pitch. And so it's kind of brought into sharp focus this whole idea about the causes of sudden death in athletes. And the different causes of death that we talk about, and these are like structural causes of death in young athletes. The common causes that we talk about are things like hypertrophic cardiomyopathy, arrhythmogenic right ventricular dysplasias, congenital aortic stenosis, and coronary artery anomalies. And this is a very busy slide. I don't want you to concentrate on it, but the perspective is that coronary artery anomalies accounts for just 1% of the abnormalities compared to coronary artery disease, which is much, much more frequent. But having said that, it accounts for something like between 5 to 30% of sudden cardiac deaths. And depending on which literature you look at, hypertrophic cardiomyopathy and coronary artery anomalies vie with each other as being the commonest cause of sudden cardiac death in young athletes. And the only thing that I would like to draw your attention to is this paper here, which was by Eckart et al. In 2004. And what they did was, this was basically the American Armed Forces Registry, and they looked at a 25-year period of young army recruits, 6 million of them, and they kind of looked back at the literature of this to find out how many of them dropped dead suddenly during exercise or soon after exercise, and what was the commonest cause of death in these patients. And they came across 126 non-traumatic sudden deaths, which were kind of exercise-related in these patients. And they found that half of them were related to coronary artery abnormalities. And when I say coronary artery abnormalities, 33% was actually coronary artery anomalies, and I'll go through some of the pictures for you. So it's a very important cause of death, and it's very important for you to recognize that on your CT scans for coronary artery angiograms that you would be performing or are already performing. So 51% of the non-traumatic sudden deaths in the young athletes were actually related to coronary artery abnormalities. 33%, if you really want the figures, is the anomalous coronary arteries. So apart from the fact that it kills you off, it can do lots of other things as well. It can cause endocarditis, particularly if you've got a coronary artery fistula. It can cause heart failure if you've got left to right shunting, which you get in patients with anomalous origin of the left coronary artery from the pulmonary artery. It can cause myocardial ischemia, either as a constant feature or as an episodic feature. And then you can also get atherosclerotic changes, particularly in fistulas, because of this constant sort of pressure changes that are occurring in the fistula. So there are a number of reasons why you need to recognize anomalous coronary arteries. And the approach has to be an anatomical and functional approach, and I think this is where working together, as Tarun was saying, i.e. the radiologist and the cardiologist working together is quite useful, because we as radiologists are very anatomical in our approach. The cardiologists are very functional in their approach, and it's nice to have that combined approach to coronary artery abnormalities, because I can describe loads of anomalous origins, but does that mean anything is something that I might not necessarily be able to understand. But sometimes, particularly when we're starting off, it's useful to have the cardiologist sitting next to you so that you can sort of scratch your brains together and decide whether this is functionally significant or not. There are a number of different imaging modalities you can use. You can use conventional coronary angiogram, you can use echo, you can use CT, you can use MR, you can use a whole load of things. But each of these are with their pluses and minuses, as with all techniques. Conventional coronary angiogram can pick up, and this is sort of based on studies, only half of the abnormalities. And one of the commonest reasons why we tend to have a CT angiogram referred to us from the cath lab is because of failure to cannulate. It's like have been fishing around for the ostium of the right coronary artery, can't find it, please tell me where it is. That seems to be one of the commonest sort of referral patterns from the cath lab, which almost inevitably is due to an anomalous origin of the coronary arteries. Echo, yes, the advantage is that it's non-ionizing, but it can only trace the ostia in the proximal portion of the coronary arteries. It's not good at picking up the distal portion of it. MR sounds nice as well because it's non-ionizing, but its spatial resolution is not as wonderful as CT. The spatial resolution of MR is about 1 to 2 millimeters. CT, you can get these really fine slices between 0.4 to 0.6. And in fact, on your workstations, you're working on 0.5 millimeter coronary CT angiograms. So MR, and again, MR, because its spatial resolution is not so good, it's best for proximal and mid segments, a bit like echo, not really very good for distal segments. It takes forever to do a coronary MR angiogram compared to a CT, which can occur in milliseconds. And having said that, a large number of segments cannot be evaluated, anywhere between 30 to 50%. So it has its limitations. I mean, I would put a patient through a coronary MR angiogram if it's a young patient, and as a cardiologist, you're saying to me, I just want to know if there's anomalous origin. I don't want to know about atherosclerosis, blah, blah, blah. In that case, I would put that patient, because he's young, I'd just put him through, and I would literally just get a 3D coronary angiogram of the coronary arteries, the origins and the proximal portions. I wouldn't try and do the cine functions and quantification of this, everything, you know, so that's what I would do, and that would take, even having cut down on all those sequences, it still takes about 20 minutes to half an hour to get the images, okay? This is one of the beautiful pictures of coronary MR angiogram where you can see the left mainstem quite nicely and you can see dividing into the LAD and the circumflex. Bear in mind, in real life, it's not very often you get such pretty pictures with coronary MR angiogram, okay? So I'm just showing you one of the best ones that we've had. So in order to understand abnormal anatomy of the coronary arteries, you need to understand what normal anatomy is. And most of you are familiar with it, I hope. Certainly I know the cardiologists will be familiar with it, and I'm sure a lot of the radiologists will be familiar with it by the end of this course. This was all sort of done by, the work all started by Leonardo da Vinci way back in the 1500s and 1600s, and then it's kind of slowly progressed. But what you need to remember about coronary arteries, what do you mean by a normal coronary artery is that you tend to have two ostia, one on the right, one on the left. Okay, so if you have more than two ostia, you've got to stop and think, what's happening here? The coronary arteries arise from the right and left anterior sinuses at the aortic root. So if they start arising from elsewhere, so the right coronary artery will arise from the right anterior sinus, the left coronary artery will arise from the left anterior sinus. So if there's any other origins, then you need to again stop and think. Usually the coronary arteries arise at an angle of 45 to 90 degrees to the aortic wall. And you have a proximal trunk only on the left side. So the left main stem will divide into the LAD and the circumflex artery. And it's predominantly an extramural course. It's an epicardial course from the ostium to the destination, and it becomes progressively smaller from the base to the apex. And it terminates in a capillary bed. So this is what constitutes normal coronary arteries. So if you get anything abnormal at any point from the origin to the termination, you need to stop and stare hard at those images, okay? And so this is the anatomical approach that I've been talking to you about. Where does it arise from? Where does it go? Where does it terminate? In other words, what does it look like from start to finish? You need to look at the rest of the heart, which is what Tarun's going to keep talking to you about as well, because sometimes coronary artery anomalies are associated with other abnormalities like tetralogy of Fallot's, like transpositions, like pulmonary atrasias with intact ventricular septum and so on. So you need to look at the rest of the heart and look at the whole sort of picture. Very busy slide. I don't want you to look at all this and try and memorize all this. In short, these are anomalies of origin, anomalies of course, anomalies of termination. And all I'm going to do now is just throw a lot of pictures at you, because these will all be examples of all these different categories that I've talked to you about. I think they should be there in your handout, so I'm sure you can sort of go through it. So anomalies of origin, you're talking about a high origin, right? What do I mean by a high origin? If you remember, I told you that the ostium is supposed to arise from the right or the left coronary sinus. Okay, so this is the coronary sinus here, which is bulging out, and that is the sinotubular junction. So when I say a high origin, I mean a coronary artery arising above the level of the sinotubular junction, as you can see quite clearly here. So you've got this little sort of bulge of the sinus, And then you've got the sinotubular junction, and this is arising above the level of the sinotubular junction. So that is a high origin of the coronary artery. Is it clinically significant? Not really. Yes, for you in the cath lab, you can't cannulate it, and then you will come down to me and say, please do a CT angiogram, and I'll tell you, yeah, the ostium is a bit higher than where you would expect it to be. But generally, a high origin is not considered to sort of cause a major problem for the patients. If you remember, I told you you're supposed to just look for 2 ostia, one on the right, one on the left. So if you get multiple ostia, you're sort of sitting there and thinking, well, what's going on? So here, for example, you've got an ostium here from which your right coronary artery arises. There's an ostium here from which the left main stem arises. But in addition, there is this small little ostium right next to the right coronary artery, arising from the right coronary sinus. And you're thinking, this can't be normal, because there's supposed to be just one on the right and one on the left. So what this is actually, it's a conal artery, which normally arises from the right coronary artery, but here, for some reason, it's just taken its own separate origin from the right coronary sinus. Again, nice to tell you that. Does it matter? Not really. Okay. This is on the left side. Now, on the left side, if you remember, I told you again, there's one ostium on the left. You've got one common trunk called the left main stem, and it divides into the LAD and the circumflex. But here you can quite clearly see that there is no left main stem. Instead, you've got 2 ostia, one of the LAD and one of the circumflex artery. Okay? And that's another surface shaded display showing you the same thing again. So this is, again, something that you need to be aware of. Perhaps this is probably, if one of the arteries gets occluded, you've still got the circumflex artery here. But this is an anomaly that you need to be aware of. Again, failure of cannulation or difficulty in cannulation can be a problem in these patients. And sometimes you can have a single coronary artery. This is actually meant to be a slide that plays. I'm not sure whether it will. Okay, it's not playing, but what it's trying to show you is that instead of having 2 ostia with 2 vessels, here we've just got one common trunk here, and then that's dividing into the right coronary artery, which is going into the right side, the LAD, which is going into the interventricular septum, and the circumflex artery, which is going on the left side in the left AV groove. So you've got one single coronary artery splitting into 3. And that obviously is a bit of a nightmare, because if that gets blocked off, then you are in a bit of trouble. Okay, so that is the origins, but you can sometimes have abnormal origins. So you're expecting them to arise from your coronary sinus. And here you can see that there's a right coronary artery which is arising from your right coronary sinus, from the aorta. But the left one is arising from the pulmonary artery here. Okay? So this is an example of an anomalous origin of the left coronary artery from the pulmonary artery, which is called ALCAPA, as you all might be aware. And this is a CT showing you the same thing. This is your aorta, this is your pulmonary artery, and you've got this vessel which is arising from the pulmonary artery, and even here in the coronal section, which is then going down the left interventricular septum. So this is an ALCAPA, or an anomalous origin of the left coronary artery from the pulmonary artery here. And what usually happens is, because this coronary artery is a high-pressure system, it's going to drain into your pulmonary artery. So you get like a left-to-right shunt. And so rather than supplying the left ventricle, all the blood's kind of going into your pulmonary artery. And so the right coronary artery tries to beef up to try and supply, and you get a lot of collaterals developing as well. The idea being to try and supply the myocardium of the left ventricle. So what you will get with an ALCAPA is an anomalous origin of the left coronary artery from the pulmonary artery, and I think Tarun will take you through some examples of it. But in addition, what tends to happen is a compensatory mechanism. The right coronary artery dilates, you get lots of intercoronary artery collaterals, and in fact, you've got some bronchial arteries arising from the descending aorta. Even they try to do their little bit, and you get a lot of collaterals going to the left myocardium of the left ventricle there as well. Okay, so this is what an ALCAPA tends to look like if the patient survives his infancy. So the ALCAPA, it's essentially, well, it's got a fancy name to it, Garland White syndrome, for those of you who like to know syndrome names. But essentially what it does is it's a coronary steal phenomenon into the pulmonary artery. And because of that, you've got large right coronary artery with extensive collaterals between the right coronary artery and the left coronary artery. And the majority of them present in infancy, as I'm sure you can understand. And if you don't treat them, they're all going to drop off dead. And what does the surgical treatment include? I'm not going to go through a lot of details of it, but essentially you're just trying to restore the normal anatomy. So you're trying to transfer it across to the aorta by various means that you can. And I'm not going to go through those means, but sometimes it's not possible to do that because, because there might not be enough tissue for you to pull that LAD from the pulmonary artery into the aorta. So in that case, what you would do then is just ligate the coronary artery at wherever it was arising from the LAD, from the pulmonary artery, and you would just put a venous graft to it. Okay? This is the bit that I'm going to slow down and just concentrate on because you're going to see loads of it now, hopefully today. It's when the coronary artery is expected to arise from, say, the right coronary artery is expected to arise from the right coronary sinus, and the left coronary artery is supposed to arise from the left coronary sinus, but they arise from the opposite coronary sinus. Okay? So we're going to stop now a little bit and think about this because you're going to come across this quite a bit, and a lot of the times, it's a question of what do we do about it. I don't know the answers to it. I will tell you what are the options, and you can please feed back to me about how you guys treat it in your hospital as well. So the coronary artery arises from the opposite coronary sinus, and it may be at any level. It may be at the level of the sinus itself, or it may have a high origin or a low origin. And essentially, there are 4 courses that are described. You can have one between the aorta and the pulmonary artery, which is the interarterial course. You can have one which is running behind the aorta, which is the retro-aortic course. You can have one running in front of the pulmonary artery, which is the pre-pulmonary course. Or you can have one which is running under the pulmonary artery, which is called a subpulmonic course. Okay, so the names are pretty descriptive. So they arise from the opposite coronary sinus, and they can go either in front of the aorta, behind the aorta, front of the pulmonary artery, under the pulmonary artery. Okay? So here you've got a coronary artery. If you look at this, this is your right coronary sinus. You're expecting there is a common trunk there. You've got the right coronary artery, but your left main stem is going behind the aorta, and then it's kind of dividing into your LAD and your circumflex. So this is a retro-aortic course after having arisen from the opposite coronary sinus of the left main stem. Yeah? Okay. This is the right coronary sinus. This is the left coronary sinus. I think Ben was talking to you, when you're looking at your aortic root, the coronary sinus in relation to your interatrial septum is the non-coronary sinus, and anterior to it is the right and the left anterior sinuses. So this artery is arising from the right. It's not arising from the right as you would expect it to. It's arising from the left anterior coronary sinus, okay? And it's heading in the direction of the right AV groove. So this is the right coronary artery arising from the opposite coronary sinus, but its direction that it's taking is between the aorta and the pulmonary artery. So it's an interarterial course. This is again trying to show it in the coronal section. So this is your aorta, pulmonary artery, and it's kind of sandwiched between the two. So it's an interarterial course. This is just a pretty picture sort of showing it to you that it's arising from the left side and then it's going across and becoming your right coronary artery. Okay. This is the pre-pulmonic course that I was telling you about. So it's basically the left coronary artery is arising from the right side. It's going anterior to the pulmonary artery, and then it's going in, dividing into your LAD and your circumflex artery. So you will see all these courses today, hopefully, during the course of today, so that you're much more comfortable with the idea of identifying the abnormal sort of course of these coronary arteries. And this is what's called a subpulmonic course. So basically, if you look at it, when I've tried to sort of stretch it out, it's going under the pulmonary artery. So this is your left coronary artery rising from the right side, going under the pulmonary artery. Even here, you can see that it's arising from the right coronary artery, and then it's going under the pulmonary artery. So this is called a subpulmonic course or a septal course. Now, of all these courses, I'm not going to go into any of this because I think we're running short of time, but I'm going to just spend some time with what I've just told you. Of all those different anomalies that I told you, I said I will slow down and concentrate on the coronary arteries arising from the opposite coronary sinus and taking the courses that they do. And of all the courses that I told you that they can take, pre-pulmonic, subpulmonic, interarterial, retro-aortic, it is the interarterial course that worries us the most, because that is the one where the artery gets squashed between your aorta and your pulmonary artery. Okay? So I'm just going to spend the next 5 minutes, and that's the end of my lecture, hopefully, is that what does the interarterial course actually mean? Why does it cause sudden death? Because that's what we worry about. And you can have an interarterial course of an anomalous right coronary artery arising from the left side, or an anomalous left coronary artery arising from the right side. So which one of these is important? Okay. So if you just look at it, this is the picture that I showed you. This is an interarterial course of the right coronary artery arising from the left coronary sinus, okay? And you can see here, it doesn't quite look normal. I mean, it's got an acute angle of takeoff. If you remember, I told you the takeoff should be between 45 to 90 degrees. This is clearly less than 45 degrees takeoff. It's got a narrow slit-like orifice, and there's a difference in the caliber. The proximal bit is quite narrow, and then it gradually opens out to become quite a normal-sized right coronary artery. And if you remember, I showed you the cross-section of it, and it looks ovoid rather than circular. So this is an IVUS showing you what normal should look like and what an anomalous interarterial course tends to look like. It looks ovoid in cross-section. So why does that happen? Is that truly interarterial or not? And they've sort of dissected specimens of it. And what the conclusion is that the reason why it looks funny, i.e. it looks like slit-like and it looks like it's narrowed and it looks like a long segment of narrowing, is because this artery, actually the proximal portion of the coronary artery, is actually growing within the aortic media. Okay? So it's an intramural course of this so-called interarterial course. And because it's intramural, it almost acts like a long segment of stenosis because there's no space for it to grow because it's within the wall of the aorta itself. And because of that, it looks long and narrow. Because of that, it looks sort of ovoid in cross-section. And because of that, the proximal bit of it looks like it's a slit-like opening of the coronary ostium. All the funny things that you were seeing, and you will see loads of it today, hopefully. So when these specimens were dissected, the conclusion was that it's not truly interarterial, i.e. sitting between the aorta and the pulmonary artery. It's actually growing within the aortic media itself, and that is why you get that funny appearance of that interarterial course. And there was a paper that came out recently in Radiology last year which said, okay, there's an interarterial course. We're worried about this interarterial course because it can get compressed between the aorta and the pulmonary artery, particularly when you're exercising or you're playing football and things like that. And what they did was they looked at their loads of CT angiograms that they had done, and they looked at all their anomalous origin of the right coronary artery from the left side, and they had something like 224 cases in the last, God knows how many years that they've done them for. And they said that you can have an interarterial course which can be high or low, i.e. that interarterial course can run between the pulmonary artery and the aortic root, okay? Or it can run between the right ventricular outflow tract and the aortic root. And they followed up these patients to find out what's happening to these patients, okay? So this was called a low interarterial course, and as you go a bit more distally, it's called a high interarterial course. And you can see from this diagram here what they're trying to get at, and this is what I'll just show you in a minute. In systole, you're expecting your pulmonary artery to expand and your aorta to expand, and so if you have an interarterial course between the aorta and the pulmonary artery, that's going to get squashed, okay? But if you have an interarterial course between the right ventricular outflow tract and the aorta, i.e. the right ventricular outflow tract is going to contract during systole, you're less likely to have problems with it, okay? So the one that worries you is basically the high interarterial course rather than the low interarterial course. But having said that, please bear this in mind that this article was only about anomalous right coronary arteries. They didn't look at anomalous left coronary arteries, okay? And they were talking about the ostium, the position of the ostium of the right coronary artery. So this is in relation to the right coronary artery ostium, okay? And the conclusion was that if you have a high interarterial course, i.e. between the pulmonary artery and the aorta, it's more likely to be significant. These patients were more likely to present with angina. They were more likely to have major adverse cardiac events as compared to a low interarterial course, i.e. between the right ventricular outflow tract and the aorta. Okay. So that is what we mean by interarterial course and why it looks the way it does. It's an intramural course. Why does it cause death? Number of explanations given. It's got a narrow slit-like orifice. We've seen that, and so that collapses in a valve-like manner. Because it's intramural, it gets squeezed within the aortic wall itself. Because it's intramural, it's hypoplastic essentially, and therefore it acts like a long segment of stenosis. And then, of course, there is this, the last explanation, which is that it is actually getting compressed between the aorta and the pulmonary artery because the pulmonary artery expands during exercise. So all these things can just basically just knock off your blood flow and therefore kill off the patient. Having said that, when these patients die suddenly during exercise, very often you find they've done the same amount of exercise or even more strenuous exercise multiple times without symptoms. And you just don't know when they're going to drop dead. And there's nothing that can predict the incidence of sudden death. The size of the ostium, the degree of takeoff, the length of the intramural aortic course, nothing can predict it. So one fine day, they get up from the wrong side of the bed, they decide to play football, and they just drop dead. Okay? Now, which one is more important? Is it the anomalous right, or is it the anomalous left coronary artery that's more important in terms of its clinical significance? If you look at the literature, and this is, there's a lot of work done on it by Angelini and his team, and they basically looked at their conventional angiograms that they'd done, and they looked at around 2,000 patients, and they looked at the anomalous origin of the coronary arteries. And what they found was, you have anomalous origin of coronary arteries in a small percentage of patients. We've already established that. In their series, it was 1% of the patients. And what they found was that 0.9% of these patients had anomalous origin of the right coronary artery, and only 0.15% of the patients had anomalous origin of the left coronary artery. So in other words, anomalous right coronary artery is 6 times more common than anomalous left coronary artery. Okay? But, and this is the paper that I was telling you about, Eckart's paper, which looked at a 25-year, which was basically a 25-year review of 6 million military recruits from 18 to 35 years of age. And these were patients who were subjected to intense exercise for 8 weeks, and they looked at how many of them dropped dead. 126 of them dropped dead. And if you remember, I told you that half of the deaths were because of cardiac deaths, and that 33% of these were because of anomalous coronary arteries. But all the patients who dropped dead because of an anomalous left coronary artery were all of them had anomalous left coronary artery. None of them in this series had an anomalous right coronary artery. Okay? There was another sort of registries which was published in 2000, and Basso and his team looked at 2 very large registries of sudden deaths in athletes in the US and in Italy. And they pulled out the patients, and these are autopsy-proven cases of anomalous origin of the coronary artery. So they had 27 sudden deaths due to anomalous origin of the coronary arteries. And if you look at their series, 23 of these patients had an anomalous left coronary artery compared to an anomalous right coronary artery. So in other words, what I'm trying to tell you is that anomalous right coronary artery is more common. It's 6 times more common than anomalous left coronary artery. But what is more likely to kill you is anomalous left coronary artery. Having said that, both can cause death from this series. Yeah? So what would you do for these patients? You've done a CT angiogram. You found an anomalous coronary artery arising from the opposite side. It's going in an interarterial course. The debate is open. What you're trying to do is, obviously, you're trying to mimic the exercise conditions to find out if this is functionally significant or not. So ideally, you should probably be putting them on the treadmill and doing a perfusion scan of some sort while they're on the treadmill. If you can't do that, then the next best thing is dobutamine, because that'll increase your pulmonary artery pressures and aorta pressures, and again, try and mimic things. Adenosine is probably less helpful, because all adenosine does is just causes vasodilatation, so it's not really going to mimic the conditions that you want mimicked to find out if an anomalous coronary artery is functionally significant or not. And then, of course, there's talk about doing IVUS, because on IVUS you can see the ovoid appearance. And look at it and say, right, this is ovoid, it's likely to be intramural, it's likely to be sort of significant. And the treatment of it, it's again open to debate. I don't know what the right answers are or what the wrong answers are in these cases. Like, for example, if you have a young patient who's got an anomalous origin of the right coronary artery or the left coronary artery from the opposite sinus, it is an interarterial course, he has got myocardial ischemia on his treadmill perfusion test, life's easy. You say, right, let's treat that, let's reimplant it, okay? But a number of times these patients are asymptomatic, and then you don't know what to do with them. So there are sort of, clinical scenarios where the patient's young, and he's got an anomalous coronary artery origin from the opposite coronary sinus, but there are no signs or symptoms of ischemia. What do you do with them? Do you treat them? Do you not treat them? And likewise, you've got patients who are older than 35, and I fall into that category as well. What do you do with these patients who've got asymptomatic sort of anomalous coronary arteries? I don't know the answers to it. I guess you would, as a surgeon, you know, the tendency to operate on younger patients is probably going to be more than in older patients, because these patients are more likely to be active and be playing football and all kinds of strenuous exercises. And I guess an anomalous left coronary artery, again, the threshold to operate would be more than the anomalous right coronary artery. So it's really a combination of everything. So in effect, what I'm trying to tell you is that when you're writing your report out, you need to look at the anatomical course from the origin to the finish, which is fine, which is lovely. But then you need to then sit down with your cardiologist to decide which of these are clinically significant. So you know, for example, that an ALCAPA, i.e. a left to right shunt, is going to be clinically significant. You know that when the coronary artery arises from the opposite coronary sinus and has an interarterial course, it's likely to be significant. You know, for example, if you have a coronary artery fistula which opens into a low pressure chamber, again, that's going to result in a coronary steal phenomenon. That's going to be significant as well. So you need to highlight which of these are going to be clinically significant and perhaps make appropriate follow-up recommendations. You know, would you refer the patients on to a cardiac surgeon? Would you do stress imaging of some sort? Would you put them on the treadmill or not? You know, all these kind of things. So your take-home messages is that think about coronary artery anomalies in a young patient presenting with angina. Think about coronary artery anomalies also when the cardiologist says to you, I'm trying to cannulate this patient in the cath lab, I can't. Think about coronary artery anomalies. Know your coronary artery anatomy from start to finish, and I think I told you a broad sort of principles of what constitutes normal coronary arteries. So if there's any deviation from that, think about those deviations. Mention them, but also don't forget to mention that which of these are clinically significant. So a separate origin of the condyle artery, which I showed you, you know, I can add it for further 2 lines about that in the report, but it's not clinically significant. So the role is really to identify the clinically significant lesions and make appropriate follow-up recommendations. So that is all that I wanted to tell you about.